And on behalf of the Nephrology Society, I welcome each and everyone for today's meeting. 102. The utilization of dialysis is increasing, and hemodialysis, it remains the most commonly utilized dialysis modality. And our dialysis patients, they are living longer, and therefore the need for an optimally functioning vascular access, it cannot be undermined. And interventional nephrology has emerged as a distinct specialty, and it has impacted the outcomes and has improved the efficacy of care for our patients. And a large chunk of interventional nephrology is being practiced by interventional radiologists. And it's our pleasure to have Dr. Rajesh Mundra, a senior interventional radiologist from Nagpur, with us with interesting cases for discussion. Welcome, sir. Welcome to the Nephrology Society. And on the chair, we have Dr. Amit Pasari, eminent nephrologist from the city, and Dr. Faizan Ansari, young dynamic nephrologist from Akola. Over to the chair for further proceedings.
Good evening, everybody. As Madam pointed out, intervention radiology or backup from intervention radiologist remains an integral part for optimum management of our patients with hemodialysis. And as the patients are living longer, we are seeing more and more number of access-related complications like fistula, stenosis, TCC malfunctions. And whenever we face such problems, we have the intervention radiologist to guide us and to save us and to save our patient. So without wasting much time, I will hand over the mic to Dr. Rajesh Mundra, sir, to present his exciting cases. Over to you, sir.
Good evening, everyone. First of all, I should thank the Nephrology Society for giving me an opportunity to present the interesting cases of interventional nephrology. Just a second. Show all those. Because time given was too big for an hour or so, I thought I should share a few very interesting cases which will be of use to many of us, and the newer trends which are coming up in the field of interventional nephrology. So I will just take all small preview on everything which we perform. The purview of interventional nephrology is guided renal biopsies, insertion of TCCs, percutaneous endovascular procedures to manage dysfunctional AVF, AV graft in patients with end-stage renal disease. And a new technique which is coming up, I believe the device will be anytime readily available, maybe in anytime in India. This is the surfacer inside out device to make an unused right-sided internal jugular vein. If unused in the way, a thrombosed right-sided internal jugular vein for insertion of TCC and making percutaneous AV fistulas for hemodialysis. To begin with, I'll just start with renal biopsies. As you all are aware, everyone is doing renal biopsies for both native and transplant kidney, and we can use ultrasound or a CT guidance, which depends. If the patient is obese, we can go for a CT guidance, and or it can be a choice of an operator. Generally, a transplant kidney is done, ultrasound guided biopsy is done in transplant kidney. And it is one of the most reliable method for acquiring renal tissues for histopathological assessment. There are two types of biopsies. One is the non-focal or a non-targeted biopsy. The second is for a lesion, which is a focal or a targeted biopsy. And the other alternative to percutaneous biopsy is a transjugular renal biopsy, which we do it in some patients where it is desired. Indications you are all aware about, so I'm really not going to talk about the indications of biopsy. This is one of the patients which is 19 years old and renal parenchymal disease with proteinuria, who showed albumin traces in urine and had medical renal disease on ultrasound. So this is you can see a kidney, the biopsy needle just at the outside the kidney. And then we took a renal biopsy from the lower pole of the left kidney. And you can see a good piece of a biopsy from the lower pole, which was taken. The most important thing is we always do a post-procedural observations at 10 minutes, at least at 10 minutes, to see perinephric or an intraparenchymal hematoma, to keep a good watch on that, because they can complicate and we can have lots of post-procedural problem. Very rare problems happen if you really take up a lower pole of kidney, because generally that is supposed to be relatively avascular. I'm saying just relatively avascular. The transjugular kidney biopsy can be done in, and we have a dedicated set, a renal access and a biopsy set, which is available commercially in a market. And this is how, this is one of the patients when we perform transjugular renal biopsy. This is puncturing the jugular vein, right jugular vein. We generally go only from right jugular. And you can see now I'm entering into the jugular from the superior vena cava now into the inferior vena cava. My catheter is in the right renal into the lower pole, and then from a lower pole we take this biopsy gun and take a biopsy. You can see a good chunk of biopsy was again taken from the lower pole of the right kidney here. We prefer a right kidney in patients if we are supposed to do a transjugular renal biopsy. Generally, we mark the ciliary of the kidney over a fluoro, and we see to it that we do not cross the ciliary, because generally the patients whom we take, we go ahead and take a transjugular liver biopsies are patients with significant hypertension and patients of amyloidosis, which can bleed torrentially if you really go outside the renal ciliary. So this is one of the procedures which can be done whenever deemed fit. Again, indications of transjugular kidney biopsies are uncorrectable bleeding disorders, treatment with antiplatelet or anticoagulant, uncontrolled hypertension. A morbidly obese patient is a good patient where you can advocate a transjugular kidney biopsy. Or if you really require to take a combined organ biopsy, you require to take a transjugular liver biopsy or at times the biopsy from the heart, then you can go ahead and take biopsies from each and every organ which you really desire in that particular scenario. And at times a failed percutaneous biopsy can be an indication, but I really don't find a failed percutaneous if you are really taking the help of image, that is ultrasound or CT. The complications are slightly more than the percutaneous one, but again at the acceptable range. The uncooperative patient and uncorrectable bleeding disorders, which becomes contraindication to percutaneous biopsy, again a transjugular liver biopsy can be done. As you know, written consent and uncooperative patients, assessment of the patient's cooperation for the procedure is always done pre-procedurally. Lab investigation in a platelet less than 50,000 is a high risk, and we won't prefer doing a renal biopsy in those patients. However, a normal INR and a normal PT and PTT do not assure you that patient will not bleed after the procedure. However, the INR should be less than 1.5, and patient should have a normal PT and PTT before we go ahead and do a biopsy. We generally take a 16-core biopsy gun, use ultrasound. If required, you sedate it. We just check a formalin jar and a glutaraldehyde jar before the procedure. Technique we are all aware about, so I'm really not going to go into detail. Most important is post-procedural observation, which you all do. And generally observation is at least for 4 hours and as long as 24 hours. Hypertension and amyloidosis, they cause significantly delayed complications in a way of bleeding or perinephric or intraparenchymal hematomas. So a 24 hours observation for patients with hypertension and amyloidosis is a good time to really see if patient is complicating after the procedure. We know that perinephric hematoma, intrarenal hematoma, hematuria, AV fistula, and pseudoaneurysm can occur and they all can be treated by interventional radiology. If you again have a pneumothorax, if you are not doing an image-guided biopsy, you can have pneumothorax. Colonic injury is absolutely unheard if you are doing again an image guidance, but they are described in literature. Hemodialysis catheter insertion is another domain in interventional nephrology, wherein we know that there are two types of catheters. One is the acute and the chronic hemodialysis catheter. And the chronic one has which is buried in at the skin site for for creating a tissue ingrowth, which prevents the infection and dislodgement of the catheter in a longer run. We have untunneled and the tunneled catheter, and we all take the guidance of ultrasound and fluoroscopy to place in the catheter. We should be aware that depending upon the weight of the patient and depending upon the length, means height of the patient, there are various types of uncuffed catheters which are available, and we should pick up the length appropriately, because the distal tip is always to be placed in SVC RA junction. Because if the distal tip is above the SVC RA junction, you tend to suck the vein wall, and which can lead to inadequate hemodialysis. Same is with the TCCs. There are various French of TCCs depending upon right from pediatric to adult, and we have various French of TCC as well as various length depending upon where you are supposed to place the TCC. The location, as I said, we should keep the catheter mainly at RA-SVC junction, prefer right IJV, then left, because again the left gives a relatively inconsistent flow during dialysis. Subclavine should be avoided, as we all are aware that it can compromise with further fistula creation. And femoral vein, you can generally use an uncuffed catheter because of fungal infections in the groin, which is very common in our country. So an uncuffed catheter works well at a femoral level. Generally, a catheter anticoagulation is done with 100 units of heparin per limb, which matches the exact volume which is mentioned on the hub of the catheter, which is always to be done to prevent catheter malfunction. Indications, again, these are the patients who require an hemodialysis while the patient is waiting for AV fistula to be created or to mature. And in patients where AV fistula or AV graft is not anatomically feasible, or patients who are, because of their advanced comorbidities, are not good surgical candidates for making of AV fistula. The benefits is you can immediately use the catheter, uncomplicated, and a needle-free connection with the dialysis circuit. At elimination of the cannulation site complication, which we find in when we use the AV fistula as simple insertion techniques. The design of the catheter, because there are various designs of the catheter which are available, and they are all designed to give a good, to ensure a good adequate dialysis in the patients. The various designs, one is the split, that is the hemo split or a equistream catheter from the BARD. The other, these are the stepped catheter. You can see there is a step. The distal one is the venous limb and the proximal is the arterial limb. There are dual catheters. I have not seen this kind of dual catheters at least. And there are the symmetric catheters, which are like at the same length, you have the arterial and the venous limb. And they are designed in a way that they do not mix up while the blood do not mix up while dialysis happens. Again, the newer material is a polyurethane material, which is a stiff material and has a high tensile strength. This material generally do not break and dislodge. They can have a small outer relatively big internal diameter. So a newer material, all TCCs are made up of polyurethane. We all are aware about history, physical examination, central venous imaging, catheter insertion techniques, and all. As a rule, generally, the right jugular is preferred first, then the left, then the right femoral, left femoral, translumbar, then the left subclavian, the right subclavian, transhepatic, and collaterals. I keep collaterals much ahead than the femoral ones because I do insert lots of catheters from internal jugular vein, external jugular veins also. These are the few patients. This is one where we inserted a TCC from the right jugular. This is from the left jugular. And this is the only patient I remember till now that I had inserted the right subclavian TCC because there was no sites for fistula in the right upper limb and there were no other sites from where we could insert a TCC. So this is the only patient which I had inserted long back. This is a 57 years male patient of CKD on maintenance hemodialysis, having diabetes and hypertension. The left internal jugular TCC was removed due to infection. There is a history of right internal jugular uncuffed catheter insertion, and on ultrasound we were looking that it is an occluded one and occluded right IJV distally on ultrasound. Still we attempted, because now we were exhausting with the sites in the region of the neck. We still attempted the right IJV, but we could not negotiate the occlusion. So we had to pick up another site now. And this is what we did. In this patient, we then picked up the lumbar insertion. What we do is from the lateralmost part of the anterior superior iliac spine, we puncture the IVC in the anterolateral position below the level of L2 to prevent the injury to the right renal vein. And then once the wire is into the vein, into the RA, then the insertion is as same as the other TCCs. And you can safely place in the TCC again in the IVC and distal RA, proximal RA, I would say. The problems with TCC and the outcomes of the TCC in translumbar TCC are same as the other sites. Nothing great about it. In a very desperate situation where we really don't have anything, a transhepatic POMACAT can also be placed. This is the picture which I borrowed it from the net. Again, we place in through the middle or the right hepatic vein with a distal tip into the RA. This is a relatively dangerous method to put in a TCC because there are respiratory movements and you can have lots of arrhythmias because there is a bigger chunk of the catheter which is in the right artery. While inserting the TCC, you can have pneumothorax, hemothorax, transcutaneous hematomas, arrhythmias, cardiac perforation, thoracic duct laceration, nerve injuries, or catheter can be misplaced at times, but the chances are very, very less. So not to worry about it. We do it regularly and we'll keep on doing it regularly. The long-term care and complication is more important. We know, every one of us know about the care, and this is what we teach to our technician when we use TCC for hemodialysis. The important thing is air embolism. At times, if the cap of the hemodialysis catheter gets removed, the patient should be educated that they have to just keep in a thumb and has to rush into the hospital because air can be sucked from the TCC and can cause a catastrophic problem in patients, in these patients in the form of air embolism. Catheter, if breaks can cause embolism, most important is catheter occlusion. How to prevent catheter occlusion? What is the treatment? What is the treatment for central venous thrombosis, the central venous stenosis, and catheter-related infection? In short, I will pick up all those things. When we talk about catheter occlusion, the catheter is supposed to be locked with, this is what I found in the literature. I preferably, means I do it with 1000 units per ml, per limb, I would say. But the literature says that 5000 units per ml in every limb is to be inserted, and the amount is to be injected exactly what is written over the catheter, which is done 3 times a week. That means 3 hemodialysis and 3 times a week we should do it. Or we can do it, the heparin is flushed 2 times a week, and in 1 time a recombinant tissue plasminogen activator, RTPA, 1 milligram per limb is to be done. And this second method, it reduces twofold decrease in the risk of the catheter malfunction with no increased chance of bleeding. But again, our RTPA is a damn costly drug, and I really don't think so in Indian scenario we can really practice flushing the catheter with RTPA unless and until company comes up with 1 milligram of RTPA, because otherwise we have 20 milligram of RTPA which is commercially available in our country. What if the patient comes with a catheter occlusion? The local infusion of fibrinolytic is suggested. Generally, an Igbtcc is the only approved drug which I found it in literature, but we use urokinase, we use whatever we have. But with Igbtcc, what they say is 2 milligram of fibrinolytic in 2 ml is injected into the catheter, and this fluid is dwelled in the catheter for 2 to 3 hours. Then the catheter is irrigated and flushed, and most of the clots are removed. This process can be repeated till we restore the patency. And what if we do with this? We can increase 5 to 7 dialysis once the catheter occlusion occurs with this method. And again, if it happens, you have to repeat the procedure. The literature says that do not insert a guide wire through an occluded catheter because it can cause a significant incidence of pulmonary embolism. But honestly speaking, with the Terimo, we have done it n number of times with no clinically significant PE happening with guide wire insertion through the occluded catheter. If you can inject, but you cannot aspirate, then that is the fibrin sheath, which is creating a problem and is causing catheter occlusion. What if a fibrin sheath is diagnosed? Means you inject it and you cannot aspirate. Then this fibrin sheath can be snared out and the entire catheter can be cleared. A catheter can be removed over the wire, and a fibrin sheath angioplasty can be done. And again, over the same wire, a catheter can be a new catheter can be placed. Again, this second method of catheter removing, doing a fibrin sheath angioplasty, and replacing the TCC did not show much difference in the long-term patency. But with the advent of IVUS, that is the intravascular ultrasound, use of intravascular ultrasound, and then you are doing a balloon angioplasty till you see the entire area around the wire clear. If you do it with IVUS guided, then let me tell you, this is an excellent modality, and IVUS is now there in most of the cath labs, and this should be used. It again increases the cost, but this should be used in those patients where we see a fibrin sheath causing catheter occlusions. This is one of the patients where we used a snare and to clear the fibrin sheath, which was causing the catheter malfunction. You can see the catheter was pulled, and the entire fibrin sheath was snared out. And patient did extremely well for nearly 3 months after we snared out the entire fibrin sheath over the catheter, distal end of the catheter. A central venous thrombosis is seen nearly in 30% of the patients, and the pulmonary embolism reported with it is from 0 to 17% and is rarely reported as a cause of death. This PE is rarely reported as a cause of death. But more important with central catheter thrombosis is association of infection, and the most common infection is Staphylococcus aureus, which is seen in nearly 71% of the patients. And again, in central venous thrombosis, a low dose warfarin prophylaxis is not recommended. And we do suspect central venous thrombosis in patients who have the arm, neck, and facial swelling, prominent collateral venous pattern, and signs or symptoms of embolic complications or unexplained fever. Again, diagnosis is by duplex sonography and venography. And the conventional therapy of raising the arm and many more things can be done. You have to remove the catheter if possible. And if you don't have any other sites, you can still keep the catheter in place, and you can start anticoagulation therapy in such patients. The central venous stenosis is basically due to the injury of the intima of the vein by the catheter, and is more common if you do a subclavian vein cannulation, which we don't do it of late. And this stenosis can be seen in the brachiocephalic vein as well as the superior vena cava. Means you get a significantly longer extent of a stenosis in the central veins. This is a patient, a 35 years female, end-stage renal disease on maintenance hemodialysis, presenting with puffiness of face, a non-functioning right IJV permacath, which was inserted 9 months back, had the history of multiple SD catheter insertion from the right side. Again, we assume that there is a central venous stenosis because of right IJV TCC dysfunction. So what we did was we first placed in the left TCC. You can see a left TCC was first placed, and we didn't remove the right TCC because your left TCC can go through the same track. We never wanted it to go through the same track. Then over the wire, the right TCC was while removing the right TCC, we performed a venogram, and you can see this arrow. Here was the stenosis. Here you can see a fibrin sheath, a small contrast column which was flowing along the wire. This is more or less a fibrin sheath. So what we did was we then did a balloon angioplasty to keep this side open if we require again it for the next TCC to be inserted. You can see, and first we did it. The wire was taken out from the port of TCC. Then this wire was pushed above because I have a small sheath above it, and this wire was pulled from the sheath, and then the entire internal jugular was also angioplasted, and a good flow was achieved after the angioplasty from the occluded right internal jugular and the brachiocephalic into the superior vena cava. This is another patient, a 63 years male with hypertension and diabetes with CKD on maintenance hemodialysis, who presented with a non-functioning left IJV TCC. So we punctured we attempt to do all the punctures in the region of the neck. We failed from the right external jugular vein to enter into the brachiocephalic and superior vena cava. You can see our attempt failed. So what we did was we punctured the left external jugular vein. We could see that here is the left brachiocephalic vein and superior vena cava is occluded. Now we placed in a wire from this side from the left external jugular, and we could negotiate through the occlusion in superior vena cava into the right atrium. Did a good balloon angioplasty with 12 mm, and then placed in a new TCC from the left IJV with a distal tip well into the well at RASVC junction, and this catheter worked for nearly 7 months before it created any problem for the next time. So again, the guidelines say that a transluminal angioplasty with or without stent placement is a preferred treatment in central venous stenosis, and I prefer not to put in a stent because stent tends to occlude very early. So stent is not a good thing to be placed in the central veins for a longer term. This is one of the very good cases where I had a king TCC. You can see there was a king TCC, and this was because of some muscle sleeve which was creating this problem. One of the lumen was getting occluded, and we really could not, despite many efforts, we really could not remove this sling. So we had to do, because patient did not have the other, I never wanted to touch the left side. So what I did was I placed in a wire, and from the femoral root, a snare was placed in, and we pulled the entire TCC down, and we could remove the sling. And this patient did well, and dialysis was achieved with the same catheter. Since then, I have not followed up the patient. I still presume that the patient is maintaining well with this TCC on this right side. This procedure was done around 3.5 months before. This is one of the nightmares which I had in my practice. This was again 3-4 months back. This is a TCC for the patient had occluded. See, this was a occluded brachiocephalic and subclavian. We could still negotiate a wire distally, and we attempted a balloon angioplasty, and we did a balloon angioplasty. With great difficulties, we could negotiate the balloon, and we kept on doing the balloon angioplasty for the entire track, right? And but still, we found it difficult to negotiate this. So a smaller balloon was then placed. A smaller balloon was placed, and it was angioplasted, and then the wire was nicely. You can see this is the place where there was a stenosis. A bigger balloon was then taken to do an angioplasty at that place. But always remember, when you are doing angioplasty, this area is extremely bad. This area is extremely bad. So then we injected contrast. We could see that contrast is flowing down from there, and we inserted not over the wire, and we inserted nicely into it, but there was no flow. When we injected contrast, we could find that it is in the contrast is into the pleura. I was really worried because this can cause pneumothorax and a major complication in this patient. But luckily, there was nothing, no complication. I just removed the TCC, but patient required a TCC to be placed. So what we did was, at present, he had an uncuffed catheter in the left femoral. So because we wanted to insert another TCC, we took a translumbar route, and then we presented, then we see again the right femoral was occluded distally. This was a common iliac which was occluded. So again, when we injected the contrast into the IVC, we then punctured the IVC translumbar method. We negotiated the wire into the IVC. Once your wire is down, you can place a translumbar catheter very easily. This is one of the out-of-the-box case which we did a few months back with Dr. Khetan and Dr. Ramteke at at Kingsway. This is a 39-year-old male, end-stage renal disease on maintenance hemodialysis. The left brachiocephalic fistula at the elbow. The patient presented with painful upper limb swelling. You can see this painful upper limb swelling. The color was suggestive of patent AVF. AV fistula was patent, but the thrombosed venous limb of AV fistula. And because of excruciating pain, the forced closure of AV fistula was done due to extreme pain. Despite closure of AV fistula, patient still had a significant pain. Then we had to use another imaging to find why the patient is having a significant pain. On Doppler, we could find there was one big channel in close proximity to the brachial artery, which was patent. We did a CT angio. You can see the brachial artery is significantly dilated to a tune of 12 mm. Generally, brachial is maybe 5 to 6 mm. This is double the size because of a good AV fistula. Even the brachial has hypertrophied over a period of time. You can see a big venous pouch. This was a venous pouch. I won't call it as a pseudoaneurysm. And there was again a patency. And this, you can see there is this venous pouch with again, this is a bilobed venous pouch. And this was the reason for pain of this patient. So a conventional thinking would say that you come into the brachial artery and place in a stent graft. But placing a stent graft is not a great idea because you have to start with a dual antiplatelet drugs in these patients. And again, patients are to keep this stent graft patent. But we didn't want to place in a stent graft. So what we did was, you can see, I directly punctured this venous pouch. You can see these pulsations in the venous pouch. We deployed 2 coils and then rest of the venous pouch was filled with thrombin and the entire venous pouch was thrombosed. So rather than placing a stent graft, because stent graft is a very costly affair, the stent graft itself cost to a tune of 1.6 lakhs. So our procedure was much cheaper than the cost of the stent graft. So this was a better method, and where you don't touch the native artery, you don't have to give antiplatelets to keep that artery patent, and we could successfully treat this painful swelling in the left upper limb. On table, we could see a good saturation which was maintained. This was 91, the patient was maintaining after we had embolized. And on follow-up, there was a significant regress in the size of the swelling, and the patient is still doing well. AV fistula interventions are really required because lots of AV patients on hemodialysis or AV fistula, but we don't really do lots of AV fistula intervention. Rather than doing AV fistula intervention, we prefer doing making in a new fistula because that becomes very cheap. But I would say that we should keep on preserving the AV fistula, and that can only be done if we really keep on doing a repeated ultrasound, maybe once in 3 months, once in 4 months, to find the early problems in AV fistula, and angioplasty can be answer to many of these AV fistula stenosis. Nearly 30% of the AV fistula report stenosis at 6 weeks post-operatively, and this is due to the shear stress on the venous side of the AV fistula. You can see that this is the area of stress, and where there is a shear stress, this causes an intimal hyperplasia and causes a stenosis on the venous side of AV fistula. This is the juxta-anastomotic stenosis. So what is the hypothesis for juxta-anastomotic stenosis? Because when we mobilize the vein during surgery, we disrupt the vasa vasorum. This causes to ischemia on the venous side. And when we place in a clamp on the radial artery, this also causes ischemia over there. And again, the end-to-side anastomosis of the vein over the artery, because of the shear stress, there is an intimal hyperplasia. The both cause the juxta-anastomotic stenosis. This is one such patient whom we treated. There's a juxta-anastomotic stenosis, which was treated with balloon angioplasty, and the patient did well, was doing nearly 6 to 8 months good after we did the angioplasty. Thereafter, generally, if patients do not come back to us, we lose patients on follow-up. This is one of another patient who had significant stenosis on the venous side, which was resistant to angioplasty. So we had to place a stent graft. A fluency stent graft is not a good choice, but a stent graft can be placed in such patients which are resistant to angioplasty. There are other stent grafts which are now available, which are costly, but they can be inserted to keep the venous side patent and good for hemodialysis. If your AV fistula is again failing, it has not matured, you can place in a supera stent. This is a nitinol interwoven stent, and you can see how nicely it can be folded without any kinks within. If you place in a supera stent, across the AV fistula, the 1-year patency and the assisted primary patency was very good with low intervention rate. And the primary patency was at 6 months and 12 months was 92.5 and 59.8. But this 59.8 increases if you do a single angioplasty, if you find stenosis, to 92.9. So a very good method of inserting a supera across the AVF, which is not maturing even at 2 to 3 months. We know that surgical AV fistula, when we make a surgical AV fistula, the angle of the fistula, the angle of the artery to vein, that is the fistula, should be between 30 to 46.5 degrees. And if this angle is less is preferred, But if the angle increases, then the juxta-anastomotic stenosis and lots of problem at the fistula site do keep on happening. So if you see a fistula which is not working, you can place in the supera stent. This is one of the example of placing a supera stent. This is malfunctioning AV fistula. You can see a tight stenosis over here. What we did was, you can see on an angiogram, a malfunctioning AV fistula because of stenosis. We could place in a wire across, do a balloon angioplasty. This is the case which I had borrowed it from my colleague who is at Medanta. And a supera was deployed. This is how a supera stent is deployed. You can see it is like the spring which we see in a ball pen. At the tip of the ball pen, if you see, it is a similar kind of a stent. It is an interwoven stent. And if you place in tightly over here, this can work very, very well. You can see this is placed in the arterial side as well as on the venous side. And after you deploy, you can see this paper, Australian, insertion of supera across the AVF, and you can see how beautifully a long-term patency is seen after you insert a supera. A very good flow on Doppler, which was achieved after placing a supera. This is another 82 years old man wherein a supera was deployed and a good patency of AV fistula was maintained in this non-working AV fistula. You can also convert your unusable AV fistula into a functioning hemodialysis access. And we all know that you can do a percutaneous transluminal angioplasty or a balloon assisted maturation of AV fistula. But if you place in a stent graft on a venous side without getting into the arterial side, you can still get a good maturation, provided there is only one stent. I am not saying that any of the stent graft can be placed on the venous side. Only one Viabahn endoprosthesis can be placed. Unfortunately, the Viabahn was pulled out of the Indian market a few years back because this is again a costly stent graft. But the results have shown that if you place in a Viabahn in a non-usable or an abandoned AV fistula, these which were over a period of 3 years, in this 12 patient, 9 patients had an percutaneous transluminal angioplasty done, which had failed. And in 3 patients, balloon assisted maturation had failed. In all these 12 patients, a Viabahn was placed and one could restore a good AV fistula for hemodialysis. And the fistula, and you can start hemodialysis as early as 2 weeks after the procedure. And you can even puncture the stent graft after 2 weeks. Because once you place in a stent graft, the venous side also matures, the venous wall also matures, and you can easily puncture the stent graft and do a hemodialysis after placing a Viabahn on the venous side of AV fistula. So this is one of the case. You can see a venous side get juxta-anastomotic stenosis. After placing a Viabahn, the patient really did a wonderful long-term follow-up of this patient, and hemodialysis could be achieved after placing a Viabahn. Few recent advances which we are supposed to know. When we see a when we see a central venous occlusion and failed recanalization, what do you do? Do you have anything to offer? Just imagine this kind of a scene. Here, if we have a left IJV which is patent, you can prefer and put in a TCC from left IJV. But generally, only one-sided right IJV is preferred in entire Western world. So this is one of the methods which is being described in literature. I believe this device will very soon come in India and was delayed just because of COVID pandemic. But this device is a beautiful device which can restore the patency in an occluded right IJV, and we can place in TCC from an occluded right IJV. And how do we do it? This was first described by Eli et al. And this is one of the modified methods of a transseptal route where a cardiologist wanted to place in a pacemaker wire from the occluded right central venous occlusion. I would just show you a video, and that itself will suffice. But the most important thing is that how we can do it in an occluded central venous veins. It can be done only on right side, occluded brachiocephalic or an occluded internal jugular. If you see a cross section at the region of the thoracic outlet, you see the right and the left the left and the right brachiocephalic. Above the left and the right brachiocephalic structures, and you only see a soft tissue and a clavicle and the skin above the central veins over there. So you can easily come in, you can puncture and enter from here. The arteries, the nerves, and the other important structures, they generally lie posterior to the central veins. With this, a surfacer inside-outside system was used to really puncture the occluded brachiocephalic trunk. And I will show you the video, which is self-explanatory. Only the right femoral route is preferred because it keeps you in the same straight track. You go up to the occluded brachiocephalic trunk. You can see, and then inside or outside device, this is the needle, and you have to push this needle way above the level of the clavicle. This is the clavicle, way above the level of the clavicle. This is a mark which is kept above the clavicle. There is a small hole through which a needle comes out, and through the marker which is placed above the clavicle, the needle comes out, the wire comes out, and once the wire is in, you can easily place the TCC over a wire from the occluded right brachiocephalic and internal jugular vein. This catheter, I believe, whenever we go in the next conference, we can really procure it, buy 2 or 3 pieces, and this can be easily done at our center. Then, a percutaneous endovenous fistula formation. We should be aware, though this thing is not available in our country, we have seen that the fistula, which were first made in 1966, which was reported by Simino, there was no major advancement in AV fistula creation till recent years, unless and until there was a percutaneous AV fistula formation. The fact of surgical AV fistula is nearly 20% thrombose acutely. Mean maturation time ranges from 4 to 6 months. Mean maturation. Some may mature early. The failed maturation rates are 20 to 60%. Up to 3 to 4 interventions per year are required to maintain the functional patency of AV fistula, and thrombotic occlusion rates are as high as 25%. And loss of patency is associated with significant morbidity and subsequent reliance of the dialysis catheters, which have been associated with increased mortality and morbidity again. So with this idea, people kept on thinking about making a percutaneous AV fistula. We also know that there is a shearing stress which causes a juxta-anastomosis stenosis. And with this percutaneous method, you can make, without even operating, a hole in the artery and a vein which communicates at the place itself without bleeding, can be done with endovenous RFA, radiofrequency ablation. So why need a percutaneous endovenous AV fistulas? Because of the shortcomings of the surgical fistula, because of the skin incision, the vessel dissection and translocation, and sutural anastomosis problems are seen in surgical AV fistula. And that leads to long-term complications, failure. So for a percutaneous AV fistula, the indication is you should have this perforating vein. This is most important vein, which communicates the deep vein with the cephalic vein and the basalic vein in the region of the arm. if you have this vein patent on Doppler, you can make a AV fistula between the ulnar artery or the radial artery and the radial vein. It is a fistula between the artery and a deep vein, not a superficial vein. And once the fistula is created, the blood is pushed through this perforating vein into the cephalic and the basalic vein. So we have now two veins in the region of the arm for cannulation. Generally, the basalic is deeply situated, so we may require to transpose this basalic vein superficially in patients. And this is again a new site of AV fistula. The surgical site of AV fistula in the cuboidal fossa is again between the radial artery and a superficial vein, that is a cephalic vein. Here it is the radial artery and a deep vein. So you can, if you are exhausted with a surgical fistula, you can still do endovenous endo-AVF, provided your the cephalic and the basalic vein in the arm are patent and you have a good perforating vein over here. So the system which are available is wavelink, which is from the Bard, and the ellipsis endo-AVF, which again has a relatively more complicated waving. So how do we do it? This is a small video about the wavelink. These are the 4 French catheters. You can puncture the brachial artery and a brachial vein in the above the elbow, just above the elbow, and you can place in a catheter from here into the radial or the brachial in the proximal segment before it gives any branches. But with a 4 French catheter, you can also puncture in the distal forearm, and you can go in a retrograde fashion from the radial artery. Here you can see one sheath and the another sheath. First is in the artery and the second is in the vein. And now, once you take in access into artery and a vein, you have to just place in the 4 French wavelink catheter. Everlink is now wavelink because Everlink was 7 French, and wavelink is 4 French. One is placed from the arterial side and other is from the venous side. And there is a magnet which is at this region. Once you start the machine, they just attract and they come in close proximity. The artery and this both catheter comes in. And then from the venous side, this is from the venous side. You start, this is a small ablating electrode which is popped in from the venous side, and you burn this anastomotic area between the artery, the venous wall and the arterial wall, which seals of its own because of radiofrequency ablation. And as soon as you make it, you remove it. While removing, you can just block in the deep veins so that the entire flow is directed toward the cephalic and the basalic vein in the region of the arm. So the deep vein can be coiled so that nothing flows through the deep vein. We want more flow through the superficial vein. And there is a good maturation of the cephalic and the basalic over a period of time. This is a beautiful way to make an AV fistula. And these ways do not get tortuous over a period of time. The tortuosity which we see in a surgical AV fistula, these veins generally remain in a straighter course of time. Straighter course in the entire period of time. So again, the entire procedure can be done in conscious sedation or local anesthesia, and with sonographic guidance and fluoroscopic guidance. And this is how you make a fistula, AV fistula, endo-AV fistula. The another method is ellipsis endo-AVF. Again, we have to go through the perforating vein and go into the artery. This is more difficult and cumbersome. because you have to puncture from the venous side into the arterial lumen. You take a catheter, again, then you burn the adjacent wall of the vein and the artery, and you create an AV fistula. But I strongly feel this requires a more expertise than the wavelength system, which is by the barred BD. The results between the Everlink and ellipsis have shown that the technical success is more with Everlink or wavelength than ellipsis. The maturation time is more or less the same, and the needling time is 100 and time to needle is 112 days, that is around 3 months. Ellipsis, they do take less time, and you may require transposition of the basilic vein because it is deeply situated. The brachial vein embolization is done in few patients because we don't want the vein to rush into the deep veins. And percutaneous angioplasties is done only in 2 patients while out of the 12, while in nearly 77% of the patient out of the 14, you require an angioplasty with ellipsis system. So Everlink is better and a simpler procedure, which can percutaneous AV fistula. So with final conclusion, I would like to wind up my talk by saying that fistula surveillance by ultrasound is mandatory by a person who treats it. It is not to be, not a routine radiologist is to be asked, how is the fistula looking like? Because unless and until a person understands the treatment part of it, the fistula surveillance is not to be done by them. We are there to help you out if you really require a fistula surveillance to be done, which should be done, I believe, once in every 3 months. We should do a wide awareness about preserving the superficial veins in the upper limbs, because we really require lots of AV fistula to be made. The various methods of preserving failed AV fistula should be utilized before attempting a new fistula. And an endovenous AV fistula is few years away from India and will be a game changer over a period of time. Thank you so much.
Thank you, sir, for that excellent presentation. I just had one question.
Right.
Are you putting iliac vein permacath, sir? Well, rather than putting it into the femoral vein, can we put it into the iliac vein?
No. Iliac vein are more deep, and they are into the pelvis. So puncturing iliac vein is not easy. And the most important thing, if you accidentally puncture the artery in that region, you are gone. And the most notorious artery in the body is external iliac artery. So I always prefer, and there is no literature which also tells me that we should get veins. But inserting into the IVC below the level of L2 vertebra is a well-described method, and it gives a very good long-term patency.
The house is now open for discussion. If anybody has any questions, they can post them.
I think it is a high time that we all nephrologists should learn our own interventions.
There's no doubt.
And yes, definitely Dr. Rajesh and Atul are there to help us out in many difficult situations. But then I think during our training and even post-training, we should learn interventions ourselves, so that like other specialists like cardiologists, gastroenterologists do their own interventions. We as nephrologists are probably lacking in it. And I think the younger nephrologists should take a lead and at least develop that specialty, which some of the nephrologists have already started doing it in mainly metropolitan cities. But then I think at our level, at maybe Nagpur, I don't think any nephrologist is doing interventions. So I think one young nephrologist should go and train himself in interventions and work only as an interventional nephrologist maybe. And so it's definitely a very good subspecialty of nephrology we can have. And yes, the interventional radiologists are doing wonders for us and helping us in very difficult situations when we fail to put TCC ourselves, then we are stuck up with central venous stenosis. So many places, like the one which Dr. Mundra showed, that patient had aneurysm of the AV fistula. That fistula was closed because it was a very high output fistula, and patient was getting admitted with a recurrent heart failure. So the cardiologist recommended that you get the fistula closed, then only your heart function will improve. So we closed this AV fistula, got a new fistula done in the on the other side. We could not put a temporary catheter in the IJV, so we put a femoral catheter and dilate the patient through that femoral catheter. And despite closing the fistula, the patient surgically, we thought that the aneurysm may close down and the pain may subside. But then the aneurysm persisted, the pain persisted, and we had to take help of Dr. Rajesh, and then the patient got relieved. So Rajesh and Atul are helping us and on many occasions when we got stuck up. He has also done a lumbar catheter of one of the patients of Dr. Acharya at Kingsway. So, and that patient is doing really well. That there is no flow problems with that lumbar catheter. That was the first lumbar TCC which was done at our, and we saw, like we had not seen any lumbar TCC before that. So I think we are all still learning to learn our own interventions, and definitely we are seeing our radiology colleagues who are doing intervention and slowly learning from them.
But sir, fistula surveillance is something which we should do, sir. Because
Rajesh, whatever you showed the figures, I have found that they are not as high in our situations. We do not see that many fistula failures what you have shown in your talk. Those
this is what
are not there, and most of the patients do well. Yes, there are some patients wherein everything fails, like you keep on doing one fistula after other, one catheter after other, and then that patient is left with no choice.
But a big study is going at Medanta regarding this Supera stent, sir, and they are having a wonderful result. Just to tell you, because I just wanted to share you, because unless until we know, we really can't give the choice to the patient. But it's a beautiful stent to be deployed. We routinely keep on deploying this stent in the region of SFA in the thigh and up to across the joint in the knee region. And it's a beautiful stent, sir. I can really give you a hands-on experience of that stent, and you will find that this stent doesn't kink at all.
For that juxta anastomotic.
Yes. So just to tell you, because there are few patients which do not mature, AV fistula do not mature, something. If we can give that choice to those patients, because AV fistula still remains as the best.
The problem is only cost.
I know, sir. I know.
Basic problem is cost. Otherwise, interventions are good and should be tried in more and more patients. But
I agree.
The limiting factor is the cost, and our basically the population which we are catering are not that affluent and able to afford that kind of treatment. So I think, but still we have come far ahead.
Exactly.
We are slowly progressing. So maybe in the years to come, we'll have that class of patients also.
And it was just my idea was to, I borrowed that slide from my colleague from Medanta just to show it to you, because rather than borrowing the videos from, from some presentation, I just asked him, because Viru is doing a significant amount of placement of supera across the AV fistula with a wonderful result. And that study from Australia has shown a very good outcome in those patients where AV fistula fails. So it was just like, I wanted to show it, because unless until we are aware, we won't be in a good position to advise what can be done for those patients who are having a non-functional AV fistulas.
Any other comments from Manish? Pezan, you want to speak?
Thank you, Dr. Rajesh. It was a wonderful lecture, very amazing slides and picturization of all the interventions. I really liked it. It was very informational. And I agree with the seniors, Dr. Prakash, as said correctly. It is high time that the nephrologists should also learn the basics and should be aware of all these procedures, because because the end stage kidney disease patients are with the nephrologist for a long time. They develop a special kind of attachment, and we are aware of their needs. Otherwise, so we are at the very first place, and it will also help us to diagnose the problem very early and address it. Because a lot of time the interventional radiologist or other intervention specialists may be busy at some times to refer a patient, and there might be some delay. So it's always better that we as a primary treating physician should always know. And also Dr. Rajesh has also highlighted that follow-up Doppler should be done by the treating physician, so that we are first to diagnose the problem, what's happening, and also guide them properly, and also initiate the correct and treatment on time, so that complications are least, and the fistula or the AV excesses are salvaged at the earliest possible. So I thank you, Dr. Rajesh, for enlightening and giving the update about the many advances which is happening in this emerging field called so-called interventional nephrology, which many nephrologists know very least about it, and like the supera stents, surfacer, which is now upcoming procedure. I would have one question about like you explained about the intravascular ultrasound about removing the Fibrin sheath. I was just wondering what would be the cost of. You explained it was very costly. So what?
Not very costly. Of late, every cath lab, means even at Kingsway, and every cath lab has IVUS.
Yes, sir.
It is just an experience. You take it over a wire, see how big is the sheath, and you keep on doing repeated angioplasty. Use snares to remove that sheath, because till the time that sheath is, you cannot have a good dialysis. Why? Because as soon as you suck the blood from there, the sheath will go and will at some of the holes, and it will block the catheter. And the cost of IVUS, I believe, at Kingsway is somewhere around 65,000.
Okay.
And I strongly believe, and we can work with Khitan sir, and if we can bring down the cost, I know, but bringing down the cost at corporate becomes relatively tougher. Relatively tougher.
Okay.
I don't.
So another question: do you otherwise do venoplasties in central venous obstruction, and any experience with venoplasties in central venous obstructions?
Yeah, I do it. These are my slides. Yeah. These are all my slides, except for.
Yes, done a lot, and that's the main forte of interventional radiologists, that they are doing central venous venoplasty, central venous stenosis. And what is the cost of, Rajesh, transjugular biopsy, and how many you have done till now?
Sir, honestly, only one in Nagpur. Again, the cost would be somewhere around a tune of 40,000 rupees.
40,000.
40. It is costly, sir.
No, 40,000 that way is not very
In my
costly.
setup,
If we
sir,
consider-
in my setup,
consider other charges, then I think 40,000 is not that much.
in my setup, sir.
40,000 is okay. And for a obese patient where the risk of bleeding is high, I think
In my setup.
40,000 is not much. But because other procedures cost much more, like
Exactly.
putting coils, and then other things are quite expensive.
My only
Beyond
aim,
1 lakh.
my aim to start my own setup was the only way I should make it in a relatively, because I don't want to earn more out of it. I want to spread more of interventions to many, so that people are aware about the procedures.
Exactly.
So for a bilateral central means bilateral stenosis of internal jugular and the brachiocephalic ones, what options we do have?
We still, madam, we still prefer doing cannulating the wire, do an angioplasty.
If it is not possible, then what options we have and how much they are used?
Translumbar. I've done, means in last year, I've done around 10 to 12 translumbar TCCs.
And you said that you prefer it over femoral ones.
Because many a times the groin, you have fungal infection and many more problems. So going through an infected area is not a great idea. That is the only big reason. At least in Indian patients, we find it difficult because of infected groin. People have bad hygiene.
And how much does it cost?
It should around 50,000.
And
50,
the
50.
cost for removal in case of a problem?
I charge 5,000.
Okay. So because it requires some kind of embolization also, no? When we remove.
Embolization with gel foam. Gel foam plugs. I don't embolize using coils and many more things. You have to withdraw it slowly. You have to keep on embolizing with Abgel, a large Abgel. The way we treat the lacerated liver, the surgeons do in a lacerated liver, and that works very well while we remove it. And there is significant amount of fibrosis which forms in the region of the tract.
So usually femoral TCC can be put by any nephrologist. So,
yeah.
So that's why Rajesh is putting only translumbar, which a nephrologist finds it difficult
I agree.
to put. So that's why he's done more of translumbar than femoral.
Exactly.
Femoral is, I think, the most easiest form of TCC. Though there are its own issues, like one is again the curve which is taken, the comfort in sitting, and all those things are mobility becomes an issue with.
And DVT also, sir.
Translumbar mobility is not a problem.
And DVT is relatively more common with femoral.
DVT, we haven't seen any with, I think, femoral TCC. I have not come across any DVT. Any of our colleagues have come, they can share their experience. I haven't seen any DVT in a patient who was on femoral TCC.
But with an uncuffed, I've seen quite a few.
Yeah.
Uncuffed के साथ में तो बहुत common है. Uncuffed वाला तो वहाँ पे femoral vein thrombosis is very common, but not with TCC. TCC, I haven't seen any DVT with TCC.
And amongst the causes of this superior venous system thrombosis or stenosis or fibrin sheath, what you find most common cause for catheter dysfunction referred to you by nephrologists?
The stenosis is more common. Thrombosis patients generally do not turn to us because they are relatively more sick. They have superadded infections. So the most of the patients with thrombosis, the catheter is removed and the patient is on a higher antibiotic. So patients with central venous thrombosis are very less are referred to us. But with stenosis and fibrin sheath, yes, we see quite a few patients with stenosis and fibrin sheath.
And this surfacer will help only for thrombosis.
With no, not thrombosis, for occlusion, of any cause.
Means stenosis also.
Yes. It has some learning curve, but I found it's a wonderful device, to be very honest. And I always feel that there are patients, despite the translumbar and many more things. Again, before putting in a translumbar, I would prefer using a surfacer and would prefer placing through an occluded brachiocephalic or jugulars with surfacer device, if I had the surfacer with me. Because the relatively ease of relative comfort is much better than in the jugular region rather than in the lumbar.
And what about putting a femoral in a retrograde way? Means going from above the inguinal canal and catheter lying in the thigh.
You can definitely place. There is no problem that you can't. But I always feel that there is some discomfort in the femoral region. To me, I find it more cumbersome for patient.
So thank you, Rajesh. I think the chairpersons to take over and close the session.
Thank you, sir, for that excellent presentation. If there are no more questions, I will hand over the proceedings to Dr. Vishal for vote of thanks.
Thank you, Amit sir, and thank you, Rajesh sir, for that excellent talk on, and you covered everything about interventional nephrology. And I would like to thank the chairpersons for today's talk, Dr. Amit Pasari sir and Dr. Faizan Ansari sir, and all the attendees for today's